Thank you for having me today, and thank you also to Lee and the planning committee and the team who pulled this conference together. This is sort of one of the highlight conferences for me every year to see everyone involved in Healthlinks across the province, so really happy to be here. So my presentation, short one, is about spread and scale related to collaboration and the Healthlinks approach to care. I think Lee did a great job of presenting the progress that you all have made since Healthlinks started as this sort of vague idea in 2012 that Susan and Helen Angus talked about that floated out this idea of needing to do better for Ontario's most complex patients. Started off with a few risk takers, 22, who weren't quite sure about this but thought it was neat and thought they would give it a try. And you know, 5 years isn't a long time to see now 82 Healthlinks really thriving in terms of experimentation, in terms of collaboration, and doing the utmost to make sure that the care for our most complex patients is optimized and coordinated. You know, we always look at the numbers and the trajectories of improvement. I think what's most important to me is what's behind the numbers. And you know, we get the reports that, for those involved in Healthlinks, that you send in. I know you love preparing those and sending those in. And just the qualitative stories that we hear, and we heard from Craig today. I look forward to hearing other stories, and that's really the richness that Healthlinks bring. It's not just that we have X number of care plans, although that's critically important, or X number of patients attached to primary care, although that's very important. It's really what that means to patients and what the collaboration is actually resulting in. And the work that you've done collectively, as you know, we have a fairly ambitious patients first strategic agenda in front of us, and that much of the work that you've done over the past 5 years has really informed that work. And last year I talked a little bit about some of the key principles behind Healthlinks around, you know, collaboration and around localized planning, you know, population-based approaches to care. Have really formed the basis of a lot of the work that we're doing now in partnership with our local health integration networks to transform our healthcare system. And that's largely because of the work that you've done day in, day out. So I thought I'd start off, you know, again, weeding through some of the reports that you send in, just some examples of collaboration that we see. You know, there are dozens and dozens of different ways that Healthlinks are collaborating, are engaging patients and their families, working with other healthcare providers in the circle of care, and also extending that circle beyond healthcare to other sectors that historically we haven't necessarily had a strong partnership with, like the justice sector, like social services. You know, when Healthlinks first started, we heard from Guelph around the partnership with the Ontario Veterinary College as a key sign of an elderly person deteriorating was them not bringing in their pets. And you know, this is the extent of the collaboration that we're seeing. I remember one of the quotes in the earlier days of Healthlinks saying that it was through Healthlinks that the hospital, the primary care providers, the home and community care providers, the social service providers all sat down in the same room together. Healthlinks really brought that together, and for the first time we started to see these local collaborations occurring. There's several other examples, community conversations, excellent innovations that we're seeing in collaboration with patients and families, and all this is extending, it's incubated in Healthlinks, but extending quite beyond in terms of population approaches to care. But asked to speak a little bit about enablers of collaboration. I'm not sure if I'm the most appropriate person to speak to that, because I think you in the room can speak more intelligently about what is enabling you and what is actually hindering you from advancing a collaborative model of care that is really focused on the diverse needs of the patients that you're serving. You know, I think fundamentally we look at this balance between standardization or you know, having things the same across the province, these hard and fast rules set by the province or the LHIN, and this low rules or local customization. And I don't know if we have that balance right. I mean, we started off in quite a low rules environment, as many of you will remember. We had some broad brushstrokes of parameters, the sort of big box that everyone was to work within, but really left the how and the meat and potatoes behind the approach to local creativity, to local innovation. And we've seen a lot of great stuff come out of that. Innovations in patient and family engagement, the different types of coordinating agencies, family health teams, the voluntary sector, hospitals, CCACs, now LHINs, provider engagement, the ways in which Healthlinks are reaching out to physicians, solo physicians, group practice, nurse practitioners, others who play a key role in the care of complex patients, and the different approaches to collaboration and information sharing. And we've seen that low rules approach really help to unleash the creativity around those some examples of collaboration. We also know that some standardization is needed. Coordinated care planning and the leadership that HQO has provided in the coordinated care plan template, the focus on complex patients, the idea of setting a bit of a definition or an algorithm as to how complex patients are to be identified, as well as some other standardization approaches. And as I said, I'm not sure if we have that balance right. I mean, the scale here shows everything's quite even and we have that balance perfected, but I think that's a subject of an ongoing conversation and something at the ministry that we always struggle with is what is that balance to make sure that there is a level of common expectation that patients across the province can expect from their HealthLink, but at the same time not hindering the innovation and hindering the creativity that we've seen so important as part of HealthLinks to date. And of course, the foundation to everything is committed providers, engaged patients and families. Now, in terms of spread and scale, this is another thing that we struggle with. The ability of local health links to adapt their own approaches is great for those local health links, but often the circumstance of that health link is quite different from others. But we think that there are some common threads that can be woven through, and my time's up, so I'm going to quickly go through this. So collaboration approaches, absolutely, actively sharing knowledge. The role of the LHINs. LHINs have an important role in fostering health links, but also sharing those best practices, along with Health Quality Ontario, examples such as this conference, to make sure that dialogue continues. And I think as our sub-regions evolve and as they mature and the care communities within them, I think that creates an excellent opportunity to actually have common sub-region approaches to collaboration. Again, starting with health links, but extending beyond to more of a population-based approach to care. So apologies for going a minute over, and thank you very much for your attention today.
So good morning, everybody. As Lee indicated, I am here today on behalf of all of the LHIN leads for Healthlinks. So we are meeting tomorrow, so if I say anything wrong today, they're going to beat me up tomorrow. So part of the conversation that we wanted to have today was focusing in on acknowledging where we've been. And as Phil talked about, in the early days, that was those risk takers, those early adopters of Healthlinks that really kind of set the journey. And over the last 3 years, we've come a long way. We've, though, focused in the early days on coming up with driving some consistency, and you'll see that the font on that consistency is a little larger. We do feel that we're at the point in time in our journey where there is a need to kind of bake in some of those fundamental foundational pieces, and a lot of that we heard from you. The first one was around a pan-LHIN communications framework. We did also propose 8 metrics that were endorsed for implementation by the CEO Council. And the last thing in the focus of the conversation today is around the HSSO's leadership for us in the development of a report on spread and scale. The piece that's important about the Healthlinks is how it is foundational for how we can move forward with the sub-region development. We've learned a lot about the connections. We've learned a lot about the way that we need to work. And as Phil talked about, Healthlinks was really the way in which we brought together all of those silos of caregivers that we've been seeing within and across various sub-regions. So we want to talk about 6 levers of change that we think will be fundamental to moving forward with the sub-region development. Those, and I'm not going to read them word for word here, but we do talk about the evolving care coordination model. Through the leadership of HQO, we do have a new version of the coordinated care plan And the expectation is that we use that consistently across all of the Healthlinks and subregions so that we can be evaluating the usefulness and utility of that care plan. Collaborating with primary care. You notice that we use the word collaboration and not engagement. We think that collaboration, there's something about the mutual development of programs and services and the mutual development of care plans that's important, and not just simple collaboration, or engagement, sorry. Embedding the care approach within the organizational design. I know that within MyLIN specifically, Healthlinks is the foundation upon which we're going to build all of the sub-region collaborative work that we're going to do ahead of us. Capacity for change. This is the one that, and we are meeting tomorrow as HealthLink LIN leads. We do need to have a conversation about how we encourage and share knowledge across all of the HealthLinks. If one of our colleagues in the Northeast or Northwest has done something, I want to graciously steal it, to be perfectly honest. And I think we need to come up with a better, more formal way of sharing all of that. Formalizing the accountability is also important. There are some HealthLinks and LINs that have played around with the accountability, looking at formalizing what it looks like and what it feels like to be involved in the HealthLink journey from a more formal capacity perspective. We also, and I'm not going to steal anything from Ben, but we do need to talk about data systems. And recently, I think 12 of 14 LINs decided that we were all going to adopt the CRIS system for coordinating care plan from a digital perspective. We think that that's also an important step and stake to take and put in the ground, and say that we all need to be adopting things consistently. In particular, as patients don't necessarily recognize or approve of any LIN boundary, we need to have the way of transferring knowledge across our borders. So the other pieces that are in here, thank you. The other piece that we think is there's some secret sauce or secret ingredients that we need to be looking at and ensuring we also apply within the 6 levers of change. And as Craig articulated for us this morning earlier, we do need to have the patients consistently involved and tied to the tables, not only from a development of goals of care for themselves, but also for where we head off and where we go with sub-region planning. Primary care, again, is a cornerstone, and we need to build that in. Permanence, and that has a lot to do with the accountability. At times when we've been doing various pilots within the system, some projects are given the sniff test, and if they're around after a couple of years, then we'll take it seriously. Well, HealthLinks and the way that we coordinate care is not going to go away, so we need to reflect that as well. Privacy is probably an elephant in the room. We do need to tackle this and figure out how we can share some of that global information about the successes of HealthLinks across our various sectors. So our next steps. So tomorrow, we're all going to be meeting downtown with 14 LINs, the ministry, with HQO, with HSSO, and we're going to be talking about the information and the insights that you give us today, and how it is that we can tackle more consistency and where we can support you all in really meaningful ways. So feel free to meet any one of us and give us your insight, and thank you for your time.
To speak about the micro aspects of how we've organized and executed on HealthLinks within the Central West LIN. And I'd be remiss if I didn't pause and highlight the fact that when you think about sustainability and spread, it really takes several elements. It takes the concept of constant improvement and learning as we go. It also takes the structural piece of leadership. And in our LIN, we've had huge success in distributed leadership, collaborative leadership among many different partners. So although I'm going to talk specifically about home and community care and our journey so far, I really want to acknowledge the leadership of many other partners within our LIN. So for us, as we embarked on HealthLinks, we started back in actually 2012 when we put in our first business case. We were granted the opportunity to be right there at the front line when we were thinking about what will this look like? What is the art of the possible? So in the home and community care element, formerly the CCAC at the time, we established quickly a vision that looked at how do we execute on this concept. We believed in our LHIN that Healthlinks was not a program, it was not a project, but it was a philosophy. It was a way that we were going to challenge each other to work differently in the system. And so these were some of the elements that we landed on in terms of our vision. The integrated networks of care, we had a lot of strong isolated partnerships, but what we needed to do was now hardwire this across the entire LHIN. We wanted to leverage the skills of care coordination that we had garnered over the years and use the structure, the infrastructure we had in home and community care as a cornerstone to really help spread faster. We also wanted to ensure that we had patient-centeredness within all of our elements, and I think you'll hear many times throughout today that the magic sauce is obviously about partnerships and collaboration, but it's also about us focusing on patient goals, not provider goals. And so for us, that was an important distinction. Strengthening partnership with primary care, we had, again, pockets of some of that, but we needed to grow that. And then ensuring consistency across the Central West LHIN in delivery of care management. So for us, we basically started out in 2013 and made commitments to actually change some of our structures and some of our business process. And so we first hardwired Healthlinks philosophy or our aspects of approaching care planning with our patients into our day-to-day activities. And we did that through some painful, I'll admit, times of formal capacity building, helping care coordinators see where they were going, that this wasn't about just allocating service. This was now about looking at how do you wrap care around from a health and social perspective. So we did a lot of education with our care coordinators on the Healthlinks philosophy, how to work with primary care. We had lots of sessions supporting our care coordinators to think about how do you come into a primary care practice, give the core nuggets, and articulate what the patient needs so that the primary care and you can work together. And then we also changed some of our business processes to make it easy. So think about RI assessments that we had to do, and now you've got a Healthlinks care plan. How do we start thinking about doing those in one step within our care coordinators? And then the obvious partnership with all of our health system leaders. So our management team was really tasked, go out and make sure you're meeting with the other leaders in the community support services, in the primary care practices, in the health and social services fields. And then the other thing we did, on the right here you can see, is we actually reorganized and realigned our care coordinators into the Healthlinks sub-regions. So all of our teams moved and had the chance to be aligned to primary care. Admittedly, that is a journey. The relationship, the depth of relationship still needs to continue to grow over time, but we have done the structural alignment, and every care coordinator now knows who their caseload is with primary care. So a couple pieces around some of the innovative practices. We've taken that foundation of the structural changes we made and created some of our spread and quite frankly, our success. We started doing care rounds, again, across the LHIN. The one thing I want to stress is care coordinators across the entire organization, whether in hospital or in the community, they needed to touch everywhere. So when Dave spoke earlier about consistency in our LHIN, that was a non-negotiable for us. We had care coordinators moving all the time. We couldn't see different approaches, different practices, and so what we started setting up in each of our Healthlinks was community-based rounds where health, social providers started coming. Again, when you think of the baby steps, might have been a few people at the table at first, but over time it's continued to grow. You had to be careful about how you articulated, what are we doing? Again, many people said, well, what does a patient get if they get Healthlinks? Like, what more? Do they get more service? And what we had to talk about is, it's the way we work together as a health system that's actually different. We aligned the care coordinators in all of those rounds, and we also embedded them. So many of them now sit 1 day a week in primary care practices. They'll go to, in one of our geographies, they go to the housing and social services office 1 day a week and really spend time in that neighborhood now, understanding and working with other partners. We also focused on transitions of care, much like Lee talked about some of the practices HQO has supported. We had our care coordinators in the hospital as well as our discharge planners at all hospital sites fully understanding Healthlinks, fully understanding how to initiate a care plan, how to identify a patient who would benefit from a Healthlinks approach, and watching for care plans and also updating care plans when a patient came to hospital. Utilizing technology, so we did utilize and maximize CRIS early days to develop our care plans, share our care plans. First it was paper, then we started to include some of our partners in coming in and accessing CRIS to be able to see the care plan, and now I'm quite excited about the future where we can leverage a platform to support the sharing and updating of care plans. And last but not least, one of the innovative practices we did with our CMHA Peel partner, we knew, and we drank the Kool-Aid, we knew what Healthlinks opportunities were, and we came together and said, we're starting to see the same patient. A patient isn't just a patient with mental health conditions or isn't just a patient with medical conditions. How do we actually partner together and build capacity around mental health supports when people also have chronic illness? And so what we did is we actually garnered a few roles that allowed CMHA case managers to be inside the walls, work right alongside our care coordinators every day, and identify Healthlinks patients, and then have the right care coordination mix supporting that patient. So sometimes it was the integrated mental health consultant that was taking the lead on care planning, and sometimes it was the care coordinator with the integrated mental health consultant right beside them. So as we look to the future, we have hardwired in our sub-regions now, with all of this infrastructure that's in place, 3 main initiatives that we're going to focus on, and that's about improving access to community mental health, improving transitions of care, and improving access to palliative care. Every HealthLink, every sub-region in our area is going to tackle that. We'll tackle them a little bit differently depending on the needs in that community, but that's our consistency and our commitment. Care communities are not driven alone by HealthLink's boundaries, so it's a thought that I want us to think about. When we think about consistency, our patients are moving all over the place, so there is an important feature here. The other piece I'll challenge us all is we need system-level indicators. Our process indicators have gotten us so far, but it's now the system-level indicators. When you initiate a care plan, what was the readmission rate before you initiated it? What does it look like after? Those are the kind of metrics we're now watching. And last but not least, the ownership of patient goals needs to be with the patient, not at the provider-centric level. Thank you.
Thanks very much for having me today. When you work in digital health, it's kind of inherently back office, and the government's also kind of inherently back office. So I sort of work in the back office of a back office. So it's sort of emerging into the light of day and seeing people is very nice for me. So I'm going to talk today about the role of digital health in scaling the Healthlinks model. And I'm going to say something that I only sort of 70% believe, but I don't have time for nuance in sort of 5 to 7 minutes. So I'm just going to kind of say it. If you want Healthlinks to scale far beyond the kind of current size of Healthlinks, digital health is necessary. You just can't do one without the other. Healthlinks, I don't know how big Healthlinks should be. I'll sort of leave that to the experts. But if you want sort of double or triple or quintuple or 10 times the size, digital health is critical. And the reason that is that collaboration requires a lot of relationships with lots of different people, lots of different interactions. So when you have collaborative care, you have specialists and primary care providers and home and community care providers and hospitals and all these different groups and people that have to communicate with each other. And if you imagine sort of a small town or a village, that kind of collaboration can happen in very informal, ad hoc ways. You just sort of know the person 3 doors down. You can talk to them about a patient. It's very easy in that way. When you go to the size of a city or a province, that kind of informal relationship doesn't scale very well. And I think the good comparator for that is if you think about referrals. Referrals from primary care to specialist historically worked pretty well. In sort of small communities, it works pretty well. But at the provincial scale today, it doesn't work very well. Providers usually refer to the few specialists that they happen to know. If those specialists have long wait times, That's too bad for the patient. Hopefully they'll get a response. So communication doesn't work very well. Load balancing between different specialists doesn't work very well. And that's what you can imagine happening with Healthlinks in the future, is that you have coordination, you try to do your best at a large scale, but you don't really know who to talk to, how to talk to them. They don't necessarily trust who you are. The patient doesn't necessarily trust them. Not all patients are willing to sort of go in front of a crowd and talk about their experience. Thank you very much, by the way. So digital tools enable a scaling of things. And so if Healthlinks is to scale, digital tools have to happen. And they have to work really, really well. So the question then is, how are we doing so far? And the answer is, okay, which is a great answer. So there were sort of the low rules environment of Healthlinks, a number of tools proliferated. We, throughout 2016 into 2017, did an evaluation of those tools. We found that they all have certain strengths and weaknesses. Nothing's perfect, nothing's terrible. And that what they were relatively good at was enabling different people to contribute to care plans. They helped to avoid duplicate data entry to a certain extent. There was reasonable integration of patients and caregivers into the processes of care planning, so they did some things pretty well. But there wasn't good integration of these tools into provider workflow. Integration can always be better, and that was definitely a challenge. Primary care, specifically, was a challenge in that the tools didn't do a good job of integrating primary care, which is obviously a cornerstone of Healthlinks. And last, and I think most importantly for this talk, is the proliferation of tools, the inconsistent processes around those tools is a barrier to scaling. So the number and diversity of tools wouldn't facilitate having kind of a province-wide approach. It worked well in the low rules environment, but in sort of the shift to something more provincial and standard, the current model isn't really working. So what are we doing? First off, I want to say thanks to HQO for developing I don't know if it's been finalized, but developing the version 2 of the CCP, because the most important thing on the digital health side is knowing sort of what do you want. And having a coordinated care plan that's been sort of shopped around, that has input from all sorts of stakeholders, that actually has consensus behind it, is a huge step for us, because it gives us clarity about, okay, this is what digital tools need to be able to collect and share. So for us, that's a huge step. And helps us to move forward. We also have a really strong foundation in that we have a number of delivery partners, we have regional partners such as the LHINs, we have providers, we have patients, we have a lot of people who have bought into the system. And that's kind of a critical foundation, because you can develop all the tools you want, but if no one cares, they'll just sort of sit on the App Store and no one will use them. We're working, and Dave alluded to this, we're working now to improve solution consistency across the province. So as Dave said, 12 of the 14 LHINs are going towards CRIS as their care coordination solution, and that kind of more minimal local variation will really help in terms of improving data flow, information sharing, especially if patients go between LHINs or between Healthlinks. The kind of common solution really enables the patient movement in a much better way and enables scale in a much better way. And lastly, in terms of the foundational pieces, is that sort of the Healthlinks model is evolving, and there's sort of a growing sense of what Healthlinks are, what it means to be a Healthlink, how that integrates with sub-regions. And as that model evolves now, as we have clarity about what Healthlinks are supposed to do, our digital tools can also evolve to meet those needs. So it's sort of the model defines the requirements, and the tool should evolve and be built to support those requirements. And consistent with that, our constant mode is evaluation. We have digital tools out there, they're never good enough for us, so we are always evaluating to understand where the strengths are, where the weaknesses are, and what needs to change in order to better meet the needs of patients and providers, system planners, and others. So that's sort of the care coordination in a nutshell. I'll just, before I stop talking, give a quick plug to the fact that there's a number of other things that we're doing in the digital health space that aren't Healthlinks specific, but which I think really will help to improve care for Healthlinks patients. So we're doing a lot of work to try to improve access to virtual care services, so things like telemedicine, being able to email providers, other forms of sort of secure messaging, enabling digital self-care through things like telehome care. So there's a lot of progress happening in that space. We're trying to make a lot of progress on things like e-referral and e-consult to better enable providers to communicate with each other, because we understand that's a major challenge. Enabling hospitals to send messages to primary care providers, primary care to specialists, all those information flows don't work all that well today, and we are doing our best to get better. And we're also trying to improve information sharing around things like medication information, which has historically been a big gap. And last but not least, in the home and community care sector, there's a wide variety of, even on the very ground level, digital tools. A lot of providers feel they don't have sufficient support, don't have the tools they need to do their jobs. We're trying to do our best to improve capacity so people have what they need to do their jobs. Thank you very much.
Thanks very much for having me. And thanks to all the previous speakers who did a great job, and to Craig for the story that started us off. That's so important, especially when we're talking about data. So I'm speaking to you today in my role as a pan-LHIN lead for LHIN Renewal. And I would tell you what that means, but I'm told I only have the 5 minutes. So I'll just say that in this role, I have had the opportunity to bring my LHIN experience and perspectives to some of the provincial tables that support LHIN Renewal, and to work with LHIN teams on collaborative initiatives. And in the material I'm sharing today, what I'm bringing to you is work from the pan-LHIN, HealthLink, LHIN Leads, which Dave mentioned. He's chair of the group, a working group that put forward recommendations for consistent performance measurement across HealthLinks and LHINs. And that's been mentioned already a few times by almost everybody. All right. Oh. That was my intro slide. So many of you will be very familiar with the current state around performance measurement in HealthLinks. So we have the QI-RAP tool, a consistent tool used by all HealthLinks and LHINs that captures 2 process measures, and that gets published in a quarterly report, and that's great because we can aggregate and share our successes through those tools. But there are some limitations because these measures that we report now are process measures and less about patient experience and impact. So we can build on this. We also have some outstanding examples of local dashboards and local evaluation reports, and those are products of innovation and use of local systems to measure outcomes in LHIN areas. I think the scorecards here are from Mississauga, Halton, and HNHB LHIN. But we've lacked the ability to look broadly at outcomes because of varied ways of following patients who are involved in HealthLinks and different ways of monitoring their progress. So the key message from this really is that common measurement and definitions across the province can really serve as a key lever to enable spread and scale. As long as we have initiatives that are measuring things differently and going in different directions, it is going to be hard to build on the work collectively and really show the impact that it has. So it's time now to bring things together and to better spread and scale the HealthLinks approach to care through common performance measurement. The next slide is an excerpt from the HealthLinks Maturity Journey model, which was developed a few years ago through the ministry's rapid cycle evaluation for HealthLinks and adapted last year in 2016. And we'll be talking more about this later in the day, but what you see in the slide is the 4th of 4 domains, and that domain is measurement and continuous performance improvement. And a year ago, LHINs went through an assessment process with their local HealthLink leads and found that more than a quarter of 94 HealthLink areas at the time were not yet started with performance measurement or were just getting started. And about a quarter of HealthLinks were at level 2 of the 5 levels in the maturity journey. So they had developed a measurement plan, they had some reporting on performance based on data from multiple partners. The most number of HealthLinks were at level 3. About 30% of HealthLinks were measuring patient experience, had clear performance targets, and were identifying and implementing best practices. But only 12 of the HealthLink areas a year ago were felt to have reached level 4 or 5, where they were achieving performance targets, excuse me, integrating performance with sub-region measurement and demonstrating broader system impacts. So I imagine that in the last year we've progressed from this point locally, but I think we still need those common measures provincially to take it even further. So I think there's been broad agreement that performance indicators for HealthLinks should be expanded. That's not a new message, But we've really heard it in the last year. LHIN CEOs commissioned a report on spread and scale that Dave made reference to, and a key recommendation in that report was to align performance measurement approaches and to implement new indicators. And the ministry also put out those messages that we needed to link Healthlinks activities with system outcomes and LHIN subregions and make better use of administrative data and report in a more rigorous fashion around the Healthlinks work. So this next slide presents the recommendations for performance indicators that were compiled by the Pan-LHIN HealthLink Leads work group to add to the performance measurement for Healthlinks. And this really was to build on the leading practices that were in existence across many LHINs. And these recommendations were discussed among all the LHINs and put forward to the LHIN CEOs. And ultimately, I understand that the ministry took these recommendations and has incorporated them into the terms and conditions for the next 3 years of the Healthlinks funding. So the new indicators taking effect starting next fiscal year. So key to this approach is the requirement to have a central list of patients who register or enroll in the Healthlinks approach to care. Without that, we can't get very far. And I'll just speak briefly, I won't go into the details of the recommended indicators, but the first two here, numbers 1 and 2, are a slight revision to the QI RAP indicators that we have now, with more focus on subregion geographies and attachment to primary care. 3, 4, and 5 shown here are newer measures for which definitions and specifications are required and forthcoming. And then 6, 7, and 8 that you see here are at the level of the sub-region population. Because the Healthlinks approach to care, when it's scaled, really should have an impact on broader system measures. And those measures should align with measurement plans at the sub-region level more broadly and with LHIN accountability measures. And I have to call out just some of the developmental measures noted as well. Patient experience is such an important element of the Healthlinks work, and right now there's one here that's developmental, but I just want to emphasize how important that is. So, the next steps around this work, a task group has been recently formed to do that work to develop the consistent and reasonable definitions for the indicators so that all of us can track and input data in the same way. And the group will lead to, will develop guidelines and parameters for data collection. I know Ben mentioned the need for digital tools. I'm not sure if we'll get there by the time we start these new reporting on these new indicators, but that's going to be something that we really need to get to in the future, to have data systems that can pull measures from administrative and clinical data rather than having to double report. So it's still a work in progress, but we've taken a big step forward, I'd say, to deepening our understanding of how the Healthlinks approach to care impacts patients and families and our healthcare system.
Wonderful.